affects just the coronary arteries. This isn't a disease that just affects the carotid arteries. It affects all of our arteries in the body. It's just the ones that are more common that cause complications or symptoms are the things like the coronary arteries and such. And when you actually look at it, okay, abdominal aorta tends to be one of the more common ones, coronary, popliteal, and then carotid. So as far as the frequency of actually having complications related to atherosclerosis, you can see abdominal aorta is typically one we don't think too much about. But let's look into why this disease develops, okay? So first you gotta look at your risk factors for this. And there's a combination of risk factors that are modifiable, so things that we as patients or we as providers can talk to our patients to try to modify to make folks healthier to prevent this disease from happening in the first place. So things like, okay, if you have elevated cholesterols in the first place, well, that's going to set you up for developing this condition. If you have a normal cholesterol level, you're much, much less likely to have this condition develop in the first place. If you smoke, it sets you up for adding a lot of stress to the vascular system, and then it causes the trauma, the micro damage that occurs that actually leads to this condition developing. Hypertension, diabetes, all of those cause damage to the microvascular system. Lack of physical exertion and excessive weight leads to that. And then even high stress conditions or even high alcohol consumption can lead to all of this. So these are all things, all risk factors that we could talk to our patients about to try to make them healthier. But then there are the non-modifiable things, so things that we can't change. So advanced age, we all are getting older every second, right? The older you are, the more likely you're going to have this condition, because this is a condition that develops chronically over time. Rarely do you ever see a 1-year-old or a 2-year-old have this condition. And I'd say rarely meaning you never see it, right? But if you look at your 70-year-olds, your 80-year-olds, your 90-year-olds, you're getting close to 60, 70, 80% of your patients are going to have some form of atherosclerosis. Male gender is also a risk factor. And then, of course, if you have a genetic predisposition for having atherosclerosis, that is a non-modifiable factor. You can only resist genetics for so long before they finally catch up and can cause problems. Looking at the anatomy of the artery, there's the 3 layers, and the innermost layer is called the intima, which this is important because it is the layer that kind of controls the one, damage response, but also immune response, okay? So this is one of the most important layers because it can regulate that. Those things are great when there's an indication and a reason for it. But the immune system reacting or the healing factors acting, so like the clot formations and those kinds of things, those are bad when they're not indicated, right? Just look at your autoimmune diseases. That is your immune system acting inappropriately. And you can see the kinds of issues and things that can develop if that immune system is not being regulated properly. And that regulation occurs at the intima level because of that endothelial layer. The media is your middle layer, which is probably the largest of all the layers. And this is where your smooth muscles are located. And these are important because this is what gives you the strength of your artery. It's what gives you the strength to be able to deal with the high pressures that the arterial system encounters, especially if it's like right there in the aorta where it's getting that direct pressure flow out of the heart. So this layer is important to kind of give you that strength, but it also gives you the contractile function of the artery so that it can expand to accommodate all that extra blood, and then it contracts to kind of force that blood downstream so you don't have a stagnant blood in a vessel. So media layer is important for that movement. And then the outermost layer, the adventitia, this is kind of where all of your support stuff is located. So the blood vessels that actually provide the nutrients to that part of the artery, it comes in here. The nervous system, so that your sympathetic and your parasympathetic nervous system can regulate the tone of that vessel. That's all located in this position. So, so that would be the outermost layer, the adventitia. Going back to the innermost layer, the intima, where that endothelial layer is located, you get all of these antithrombic and prothrombic factors that just kind of dangle out there, and they work to regulate that, that healing response, that thrombotic, that clot forming response. And you kind of got this, you know, let's have some pro stuff. Hey, I need to heal. I got micro damage here, so come and help me, fix me. Or hey, I'm fine. Leave me alone. Go away. And then you know the clot forming factors will go downstream until they're needed elsewhere. But then they also have receptors on the surface that will get triggered or trigger the immune system to react if it's necessary or if it's needed. And you will see the immune cells, so neutrophils or those kinds of things, kind of working their way through this endothelial layer when it's actually triggered, so then it can migrate to wherever it is actually needed. So this layer, as we said, is the most important part for regulating those responses. Now, when you have atherosclerosis that starts to develop, these feedback mechanisms are not properly controlled. And what ends up happening is you start to develop an inflammatory response. You start to trigger that thrombotic response inappropriately, and that's what leads to the development of disease over time or chronically. But it also can trigger acute problems. When we start talking about acute coronary syndromes, we're going to talk about that, where that vessel acutely occludes, and this is the problem, and this is the thing that causes that acute kind of occlusion, because you get that thrombotic formation that blocks the vessel itself. But when we talk about this pathogenesis of atherosclerosis, there's really three parts to this, okay? And we're going to talk about each one of these parts in the next couple of slides here. The first one is the fatty streak starts to form within the wall of the blood vessel. This fatty streak develops because this LDL, the cholesterol, starts to kind of migrate inappropriately into the intima layer of the vessel. And unfortunately, this starts to disrupt the normal function of the arterial wall, and you start now getting this endothelial dysfunction, which then leads to inappropriate signaling, inappropriate development of the chemokines, the cytokines to trigger an inflammatory response. And so your body kind of starts to react to this and leads to the recruitment of immune system cells and stuff like that in order to cause problems downstream. Those chemokines, those cytokines that are released, they trigger monocytes to come in and they invade the wall. Well, those monocytes are going to recognize that the LDL, the LDL component is not supposed to be there. So what is the body naturally going to do when you have a foreign body in there? It's going to try to attack it, right? So the monocytes migrate in. They differentiate into macrophages. Macrophages start eating all this LDL, but they have no ability to digest the LDL. They consume it, but they can't break it up. So they're not really doing much of anything. And they scavenge, they scavenge, they scavenge, they scavenge, they can't break it up, they get bigger, they get bigger, they get bigger, they get bigger, and then they rupture. And now that releases all of this additional pro-inflammatory chemokines, cytokines to trigger further inflammatory reaction. And that leads to the plaque progression, where the body starts to realize that this fight is futile. So if I can't get rid of this foreign body, let me wall it off so it doesn't have an impact. So smooth muscles are recruited out of the media and into the intima, and starts to surround that ruptured foam cell, and kind of starts to wall it off and kind of keep it from coming into contact with other areas and triggering further problems down the road. Well, that plaque, as it grows and grows and grows, it can then lead to the lumen narrowing of that vessel, because that growing process has to go somewhere, right? It can't really go too much through the wall, so it's going to go through the lumen. And then that's going to subject the endothelial layer to a lot of shear forces and other things that can lead to that wall rupturing. And now all of that plaque can trigger acute occlusion or acute production of blood clots that then block the artery. And you can see that in this cartoon kind of the different phases, where that LDL, those excessive levels of cholesterol, are circulating in the blood. There's some kind of endothelial damage that occurs, i.e. things like smoking or high blood pressure causes that micro damage. That LDL gets deposited into the wall. It then triggers your immune system to activate by the releasing of these chemokines, cytokines, and then that activates the monocytes to come in, they invade, they turn into macrophages, they start eating up all that LDL, they're scavenging it up, and then they get too big, too engorged with all this LDL, they rupture, and then that triggers the muscles, smooth muscle cells to come through the media and into the intima, which then causes that plaque formation that disrupts the lumen of the artery, that then can cause that disruption, the breakage of that wall, and now that blood clot forms because it's getting exposed to all these prothrombic kind of signaling things. So that's what's happening with atherosclerosis. This is just kind of a different cartoon of it that shows you kind of that plaque formation. This one's a healthy plaque, meaning it's strong, it's dense, but that can get weakened, and you can see, you start to see a lot of additional kind of compounds in here get a weakening, and then there's a disruption in this one area here, and now all of those chemicals, those prothrombic things there, trigger that blood clot to form acutely, and now you get that acute occlusion of that blood vessel. And the next 4 lectures that we're going to do is going to talk about the complications associated with that acute occlusion. And depending on where this is occurring, it will tell you what kinds of pathologies you can encounter based on what's going on with that atherosclerotic development and occlusion. So that's how atherosclerosis develops. So it's a inflammatory condition, a chronic inflammatory condition in the setting of elevated cholesterol. Okay. But let's now start talking about how we as providers can tackle this problem. Okay. Because this is going to be the most common thing that we're going to see in our clinic is dealing with the development of atherosclerosis as well as the complications of atherosclerosis. So how do we talk about this? Well, first thing you got to know is just know the terminology behind what you're trying to talk about. So HDL is your high density lipoprotein. This is what we call our good cholesterol. our LDL is our low density lipoprotein. This is our bad cholesterol. And then, we also talk about triglycerides a lot. And I usually will explain these to my patients as this is like the building blocks for your bad cholesterol. They seem to kind of understand why that might be bad to have high levels of that. But when we look at terms mean something, right? So what are you trying to convey when you say something specific, or you use a specific term? So if I say dyslipidemia, that means that my LDL levels are high, but my HDL levels, so my good cholesterol levels, are low. So that's what you mean by when you say dyslipidemia. Hyperlipidemia is when your LDLs and your triglyceride levels are high. When I use the term hypercholesterolemia, that's when your total cholesterol is high. And then hypertriglyceridemia is when your triglyceride levels are high. Now, can you have several of these present? Absolutely. You can have a dyslipidemia, hypercholesterolemia, and a hypertriglyceridemia in the same patient. Okay? It's just those terms mean different things when you use them. So when we talk about elevated lipid conditions, we got to know that one, there are primary conditions, so genetics plays a role with these patients, and secondary, where there's other things like poor lifestyle habits and stuff that lead to the development of a hyperlipidemia. So let's look first at primary or genetic causes of hyperlipidemia. Okay, there's two types that we will talk about in this. There's the familial hypercholesterolemia, which is the problem where the LDL receptor gene has suffered a mutation. And this occurs in about 1 in 500 patients. And unfortunately, these are folks, when they have this genetic component, these are folks who tend to have premature cardiovascular disease. So this is going to be like your 20-year-old or your 30-year-old who has a heart attack. Okay. These are also your patients who could be not the typical person that you might suspect having atherosclerosis who's coming in with a heart attack. So you can only fight genetics for too long before it catches up, right? Because you don't have the normal, in this case, you don't have the normal mechanisms in place to regulate that LDL level properly, so your body's going to find other things to do with that. The other genetic primary form of this is a familial combined hyperlipidemia, where now you have an elevated triglyceride and LDL. So your LDL and your triglyceride levels are high. And again, these patients tend to have early coronary arterial disease or cardiovascular disease. So that's the primary disorders. Secondary disorders, a lot of these are things that we commonly think of that contribute to that or contribute to this. So, the lifestyle choices that lead to elevated cholesterol levels, those are there. But there are medications and there are other medical conditions that can lead to the development of secondary hyperlipidemia, such as hypothyroidism, such as pregnancy. Even some medications that we give to our patients can lead to this. Okay? And you may be wondering, well, how or why do some of these conditions tend to cause this? Well, one, for instance, if you have diet kind of changes, for instance, like anorexia, you may be wondering, well, anorexia is the consuming of too few calories. You don't think somebody would have high cholesterol if they're not eating enough, right? Well, the reason that anorexia causes a hyperlipidemia is because of that severe reduction in calories, the body starts to shut down processes to conserve energy, right? So let me shut down my LDL scavenging system in my body, because why do I need that when I'm not getting enough nutrients to maybe even meet the bare minimum to keep living, right? So that's how anorexia causes elevated cholesterol. It shuts down all those systems to regulate those levels. Pregnancy can cause elevated cholesterol, and the reason for it is that the progesterone causes an increased development or production of LDLs, because then that LDL is used at the level of the placenta to make more progesterone. Well, you need progesterone to maintain a pregnancy, so you can see why you would want to produce more LDL that can then be used to produce progesterone to perpetuate that pregnancy to full term, right? So that's how pregnancy can lead to elevated cholesterol levels. So if you have a pregnant patient who you test for cholesterol and it comes back elevated, probably not the time to actually start treating it, because it could go back to complete normal once they deliver the baby. So how are you going to approach your patients who you suspect have cholesterol issues? Well, similar to every other patient, doing that history, doing that physical is going to be important, because you're looking for the why behind it. Is it because they're eating McDonald's every day? Is it because they have a genetic history for it? Everybody in their family has this, and everybody in their family has a heart attack by 30. Look for those reasons. Then you have to actually calculate, you have to determine, do they in fact have elevated cholesterol? So you got to get labs to look for that, right? And then once you get those lab values, let's then actually assess what our 10-year ASCVD risk is. So that can help us determine what's the treatment and what's the follow-up for those patients. So so in your history, yes, you're going to be doing the things we talked about, but what's interesting also is the USPSTF does have recommendations for cholesterol screenings. So usually they say for average risk folks, if you're a male, 35 is when you're testing, and women it's 45. If there are risk factors for it, then you're going to be testing earlier. Then, as part of your history, you're going to look for any evidence of clinical ASCVD, meaning do they have a history of something, some medical condition, some pathology that is attributable to atherosclerosis. So, have they had a heart attack before? Do they have chest pain when going upstairs or exerting themselves? Have they had a stroke? Do they have peripheral arterial disease? All of those things are important in the history, because that's going to determine how do you treat and manage these patients. Your physical exam for the vast majority of your patients isn't going to really lead you to too much, but there are a few physical exam findings that if you were to appreciate this on your exam, it would tell you that they do have elevated cholesterol, and in fact that elevated cholesterol is probably severely elevated, okay? So the three things that you might notice are going to be your xanthomas, your xanthelasmas, and your corneal arcus. And examples of those for your xanthomas is this one is an eruptive xanthoma, which are kind of like these little dots that you might think is like an acne breakout, but instead of having like, white heads, this is actually yellow, and it's not necessarily erythematous around it, so it's not like an infection, a follicular infection or anything. This is actually just little deposits of cholesterol in the skin. Then there's the tendinous xanthomas, which is this firm nodules that you'll see on the extensor surfaces of the hands and the Achilles. So you'll just see these firm nodules in those areas, and that is actually LDLs, pockets of LDL, packed into those cysts. Tuberous xanthomas, these are yellowish. Don't confuse these with other conditions that cause like a plaquey kind of formation, so like psoriasis and that kind of stuff. But you'll see these yellowish nodules, again firm, but these will be common on the elbows and your knees. And then, so those are all your xanthomas. Your xanthelasma is this yellowy deposition around the eyes. And this again is cholesterol that's being deposited into the skin because of that severe elevation of cholesterol. And then corneal arcus is actually this yellow ring that you see in the cornea, and then this is lipids. So the yellow is that cholesterol, that LDL being deposited there. Don't confuse this with Kaiser-Fleischer rings that you see in Wilson's disease, where that's that copper that's being deposited in the cornea. So don't think that these go hand in hand. These are completely different conditions. It's just normally when we teach a physical exam finding, we always are talking about Kaiser-Fleischer rings, and we don't talk about corneal arcus. Then, let's get our ancillary studies. So let's do the laboratory work to one, diagnose them with elevated cholesterol. And you can see kind of an example of this. So this is somebody who doesn't have elevated cholesterol. They drew the blood, and then they spun it down and separated the plasma from the red blood cells. And this is what a normal blood sample should look like. However, if you have somebody who has severely elevated cholesterol, you can see instead of that plasma almost being see-through to a degree, it's very thick and kind of milky, almost cheesy looking, right? That is that cholesterol that's separating out in that plasma. So pretty gross. Imagine that circulating around in your blood vessels. Other labs that you're going to want to get is looking at their liver function and their kidney functions and stuff. So getting that complete metabolic panel. Because I want to see what their liver function is looking like at baseline, especially if I'm going to be putting them on a medication like a statin. I want to know what their baseline cholesterol or their baseline liver function is, because what if they have fatty liver disease? Maybe they're not going to be able to tolerate that statin therapy like they should, or like I would hope for them to do. Let's get a hemoglobin A1C because I need that value. I need to see if they have diabetes to help me determine what their 10-year ASCVD risk is. And then let me get a creatinine kinase so I can see what their baseline CK is before I put them on a statin, and then they potentially start having muscle aches or complications related to the statin. Let's get that baseline first. Now, when I first started practicing medicine, we used to chase values with cholesterol management. We no longer chase these values, but kind of giving you a good rough idea of what to expect. Usually you want your total cholesterol less than 200. You want your LDL to be less than 100. HDL, you want it between 40 and greater than 40 basically. And then triglycerides, you want less than 150. Now, I'm not going to ask you how to calculate a total cholesterol, but if you are curious on how the lab calculates this, your total cholesterol is your LDL levels plus your HDL levels plus the sum of triglycerides divided by 5. So take triglycerides, 150 divided by 5. Okay, that's what, 30. Add that to your HDL, add that to your LDL, and that's your total cholesterol. So that's how you get that value. But that gives you an idea. If my total cholesterol is 205, but my HDL is 110, say, you can see that's going to cause an inappropriate a rise of the total cholesterol. So I may think that I'm not meeting that 200, less than 200 metric, but really it's because half of my cholesterol is actually good cholesterol. So is that a problem? And that's debatable. This calculator, I'm going to teach it because that's what you're going to be tested on. But this calculator is actually being replaced with a different one that I'm going to give you on an FYI slide here in a bit. But this is the ASCVD risk calculator that's put out by the American College of Cardiologists. And when you go to calculate your patient's 10-year ASCVD risk, the information you're going to need to plug in is what's their age. The limitation of this calculator is the patient needs to be at least, this should be 40. It says 20 here, but it should be 40. Interesting. What's their gender? What's their race? What's their blood pressure? What was their total cholesterol? What's the HDL component of it? And what's the LDL component of it? And then I got to start plugging in patient history, because that history is going to be important to help me determine what their 10-year risk is. So, do they have a history of diabetes? Are they a smoker, or have they smoked before? Are they on blood pressure medications? Because if this blood pressure medication is while they're on meds for it, if it's normal, then that's great, but you still are at increased risk because you have high blood pressure, versus somebody who has a borderline blood pressure and they're taking their meds and still is borderline, and that's going to put them at a higher risk. So are they on medications for hypertension? Are they on a statin? And then are they on aspirin therapy? And when you plug in all of that information into the calculator from your patient, you're going to get 3 data points. The first data point is what is their 10-year risk? So in the next 10 years, what's the risk of them having an atherosclerotic cardiovascular disease event? And in this sample patient that I put in, they said there's a 33.3% chance that this patient is going to have something happen to them in the next 10 years. It also gives you an idea of what their lifetime risk is. So over their lifetime, this person has a 69% risk of having a cardiovascular event. And then your optimal risk. So if I were to fix all of their risk factors, like they're smokers, let me get them to stop smoking, let me get their blood pressure under control, let me get their cholesterol better controlled, what is the risk of this patient having a cardiovascular event in the next 10 years? It's 2.1%. So this is where you can give some objective data in that conversation with your patient about why it's important for us to start them on a medication, or let's try to lower cholesterol, let's try to live healthier lifestyle, and those type of things. Because that difference between 33.3% and 2.1 is significant. And that's where your conversation is by doing these things, I can drop your risk of having a heart attack, having a stroke by 29%. So imagine a 1 in 3 chance in the next 10 years you're going to have a heart attack or a stroke that could either kill you or significantly disable you. Do you want to live like that? And that's your conversation with your patient.
If you have a patient in their 30s that has some of these risk factors, you said that
that's a good question. That's what I did when I practiced. The new calculator that's actually has come out that is now getting updated in the standards of care, the practice guidelines, actually goes, I think, down to 20, 25. So it actually captured that. But with this calculator, yes, it was 40 was the start. So I would put somebody in as they're 40 and then calculate the rest. Yeah. So you've determined now that this patient needs treatment of some sort. How are we going to treat it? Similar to what we talked about from the hypertension lectures, your lifestyle modifications, your lifestyle choices are going to be vitally important to manage these conditions. So you're going to have to get your patient to buy into this. Unfortunately, it was their lifestyle choices in the vast majority of patients who got them to this condition. So it's going to take a lot of change that they have to make in order to better manage this. So what can we do from a lifestyle standpoint? And then what pharmaceuticals can we use to help us lower their cholesterol and lower their risk of cardiovascular disease? And none of this is earth-shattering. I know our patients already know this. They just assume it can't affect them, right? But things they can do from a lifestyle standpoint is, let's eat healthy and let's get active, okay? Let's eat more fruits and vegetables. Let's eat lean proteins. Let's eat less fried foods. Let's do all of those things. Let's lose weight. Let's start exercising. And then limiting alcohol, stop smoking, and then don't get diabetes. So all of those lifestyle choices, it makes sense. But those lifestyle choices are oftentimes the most difficult thing for us to do or get our patients to buy off on because it requires them to change themselves. They want that magic pill that will take all of those issues away from them, right? And yes, we do have a pill that can do that, but there's got to be some lifestyle changes. There's got to be some buy-in for it. And this is where you can talk to your patients about what to expect with dropping these values, okay? So just looking at the things that can lower your LDL. So we talk about eating healthy and physical activity, but you can see by changing your diet up, here's 15% reduction here, here's 10% reduction here, you're getting to the point where you're reaching the low intensity statin levels of response just by eating healthy. Let me start limiting my alcohol. Great, 5% reduction right there. Actually, no, sorry, that's a triglyceride. Limiting alcohol is a triglyceride reduction. Let's lose weight. So I lose 10 pounds, 5 to 8% reduction in my LDL, simply by losing 10 pounds of weight. So you can see how much of a response we can get in managing cholesterol simply by making lifestyle choices without the side effects associated with the pill. But some of your patients are going to require a pill. So what do we have at our disposal to treat those folks? Or to get a much more significant reduction in LDL? Well, your primary go-to is going to be a statin. Why is this the case? One, they work great. So we have good evidence, especially depending on which flavor or which particular statin you pick, we have good evidence that they work. So that's one of the reasons why they're the primary. The other reason is it's cheap. Your insurance companies love you for prescribing a statin, because I'm going to give you an example of another medication that works great but is significantly more expensive. So I think a month's supply of atorvastatin is about $60. Okay, so $2 a day to control cholesterol. But there are side effects that are associated with statins. We always think about the muscle things, right? There is the liver stuff, and that's why we get those baseline liver function tests. But the things that are probably most likely going to get you to discontinue a statin is going to be those muscle symptoms associated with it. So, and the muscle symptoms that they get can range from just they have muscle aches to now they're having such severe muscle pain that it actually is causing an increase in the creatinine kinase levels above normal, not necessarily excessively above normal, but they are above normal. That's why it's important for us to see and check what their baseline creatinine kinase is before we start them on a statin therapy. And then the most severe form of side effect for the statin is rhabdomyolysis, where now we're having such a profound muscle breakdown and a profound release of that creatinine kinase, but then we also start to have kidney dysfunction associated with it. So now you start to see that creatinine levels rising drastically. So what do you do if you encounter a patient who is having a side effect? Well, first of all, it's going to be, let's stop or discontinue that statin. There's no point in continuing to throw that medication at them to cause further damage if it's causing problems in the first place. So let's stop it, and let's work them up, make sure that they don't have rhabdo, and then we're going to look for other conditions that could be putting them at a risk of having and experiencing that side effect. So hypothyroidism can put them at a higher risk of having a statin-induced myopathy. Vitamin D deficiency puts them at a higher risk of having a statin-induced myopathy. So let's check for those things and make sure that those aren't going on, because if I fix those things, then maybe they're going to tolerate that statin again. Okay. If you can't find anything wrong or you fix the problem, you can then put them back on either that statin that they were on when the symptoms started at the same dose, or even maybe just lower the dose a little bit and just see what happens. Or you can just put them on a different statin. Not all statins are going to cause the same reaction, so if they were on a atorvastatin and they had a reaction, well, maybe let's try rosuvastatin and see if they tolerate that better, basically. Okay. And when you talk about statin dosing and management of statins, it's important to know that you're going to have to figure out, is this patient on a high intensity statin, a moderate intensity statin, or a low intensity statin? Really, nobody really does this anymore. So low intensity stuff, not something that we really are too concerned about. But high and low are going to be your two most common dosing schedules. And what makes these things high intensity versus moderate intensity versus low intensity is what I expect is going to be the LDL lowering level of that medication and that dose. Okay, so that's what makes them high, moderate, and low. And this is based off of studies that were done on those medications where they had the pre-therapeutic levels of LDL, they were put on it for 3 months, 6 months, whatever, and then they rechecked just to see how low the LDL dropped. So if you have somebody who is on a high intensity statin, I expect that their cholesterol levels are going to drop at least 50%. Maybe more, but at least 50%. If I put them on a moderate intensity, I expect them to drop 30 to 49%. Okay. And it's important to show, based on studies, the medications and the dosages of the medications that get you those results are atorvastatin 40 or 80 milligrams. They will get you at least that 50% reduction. And rosuvastatin 20 to 40 milligrams. So those are the only two medications and the only two doses of those medications that you should expect at least a 50% reduction of LDL by putting your patient on that. Now, if I put them on smaller dosages of those medications, so atorvastatin 10 to 20, then I would expect that 30 to 49% reduction in their LDL. If I put them on rosuvastatin 5 to 10, I expect a 30 to 49% reduction there. So it's important to know which medications will get you high intensity, moderate intensity, and it's important to know which dosages of those medications will get you there. You'll notice simvastatin is on the moderate intensity, but very few people will actually use simvastatin. This doesn't really work that well. So let's take 10 minutes, and then we'll come back and finish up talking about statins. And we talked about how they're our primary agent in order to treat elevated cholesterol levels. But what happens if we put them on a statin, we're maxing the dose out, and they're just not getting to goal? Well, what can we add to our regimens to help us get to goal, right? Well, the primary one that we're going to use is ezetimibe or Zetia, which this works differently than your HMG kinase reductase inhibitors, right? They work by actually blocking the absorption of cholesterol in the intestines. So you may eat that cholesterol, but you're just going to be less likely to absorb it. Okay, so that will decrease the amount of circulating LDL that you have in your blood. And you can see the effect that I would anticipate to have on my cholesterol level is the same as a low-intensity statin, just for this medication. So as an adjunctive therapy to a statin, you can see that synergistic improvement in your cholesterol levels, okay? So this is, when we went back to our slide here, we anticipate, low intensity is something like less than 30% reduction in your LDL. So by putting them on a Zetia or ezetimibe, now I'm expecting about the same drop in my LDL with just this agent alone, but usually not something we give as a monotherapy, but can be a great adjunctive therapy to statins. Then let's say you have a patient who, even though they're on a statin, maximally tolerated, they're on ezetimibe, and they're not getting to goal. Or let's rewind and say that this person had a severe reaction to a statin, so they had that rhabdo. What do we have at our disposal? And that's where the PCSK9 inhibitors come in. These work great. People tolerate them pretty well. The side effect profile is pretty minimal for folks. But the main reason that this is not a primary agent is simply because of cost. This is $1,200 a month. I said statins were $60 a month. This is $1,200 a month. So imagine what your insurance companies or your patient's insurance companies want to pay for it, right? So that's really the only downside of a PCSK9 inhibitor is that cost that comes with it. Okay. So that's why it's reserved to those who are not getting to goal or those who cannot tolerate being on a statin because they have a severe side effect to it. Now, before we start talking about the actual management of cholesterol, some additional terms that we need to know is primary prevention versus secondary prevention. Primary prevention is I am trying to prevent them from having their first cardiovascular event. So this is somebody who has not had a heart attack. This is somebody who has not had a stroke. This is somebody who has not had any symptoms related to peripheral arterial disease, okay? So these group of patients are people who I'm going to treat them differently when I look at my algorithm because I'm trying to prevent them from having that event in the first place. I tend to be a little less aggressive in my treatments. Secondary prevention, however, is this person has had a cardiovascular event. So they've had that heart attack, they've had that stroke, they've had that symptomatic peripheral arterial disease, and now I am trying to prevent it from happening again. Okay? So that's the difference between primary prevention and secondary prevention. And that is so important to know because when I come to my algorithm, you can see the two legs of the algorithm that I have to work with is this a secondary prevention patient or is this a primary prevention patient? This algorithm I will give to you on the test. Okay. My personal belief is this is something in clinical practice you're going to have hanging on your wall that you're going to consult. Okay. Secondly, by giving you this algorithm, I can try to teach you how to read it and understand how to work with it, and as well as how to manage the nuances of the condition, okay? And that's what I'm going to test you on, is some of the nuances of it. So please don't spend the time trying to memorize this algorithm. I will give it to you, okay? But I will teach you how to use it in the lecture today, and I will teach you how to use it in our lab for this block, okay? So, now that I'm hopefully decreasing your stress with your studies for this, let's start working through this algorithm so we can learn how to actually use it and understand what it's trying to tell us. Because behind this algorithm is a 300-page paper. So do you want to read that 300-page paper when you have a 20-minute appointment? And oh, by the way, this is probably the 5th or 6th thing that the patient's coming to see you for. You want to know how to use this algorithm. So it's just a quick reference to help you with clinical decision making. So let's first start off with our primary prevention. So this is our patients who we're trying to prevent from having that first cardiovascular event. And there's a couple of categories that these patients are going to fall into, okay? So you have your severely elevated range, so your LDL is greater than 190, so that's going to be one limb off of primary prevention. Then you have your borderline, which is 70 to 180. That's going to be a completely different limb of the algorithm. And then you have your less than 70, and that is a third leg to the algorithm for primary prevention, okay? So let's start off with our low cholesterol, low LDL. And again, this is not a value based on them being on a medication. This is, they're not on any statins, they're not on anything to lower cholesterol, and they just happen to have an LDL less than 70 when you do your routine screening on them, okay? So what do you do for those patients? Well, there's not a whole lot that we can do currently to try to get them healthier with their cholesterol levels, but let's see what their lifetime risk is. Let's just say that this is somebody who is a smoker who comes in with an LDL like this. Could we do something to make them healthier? Yes, let's quit smoking, okay? And that's what you're going to look for and counsel them about to decrease their chances that in 10 years from now, they're not coming in and now they're having an ASCVD event or having higher cholesterol and now they need medications. So the other side is now, or the other side of the extreme is now having that severely elevated LDL, where now the LDL is greater than 190. When I look down the algorithm, it says maximal tolerated statin. So think about, you're going to be putting them on a high intensity statin dose, which if they can tolerate atorvastatin 80 or rosuvastatin 40, that's what they should be on. But if they start to have some muscle aches or whatever, okay, let's cut them down to atorvastatin 40 or rosuvastatin 20, okay? But let's do the maximally tolerated dose of your statin. Then we give them a couple of months of being on that maximally tolerated statin. I then bring them back and I recheck their LDLs. If their LDL still remains above 100, now I'm going to add an adjunct. So I'm going to add that ezetimibe to try to get that LDL less than 100, okay? So we set a high intensity statin. I'm expecting at least a 50% reduction. So if they had a LDL of 220, that minimal 50% reduction with that high intensity is going to get me down to 110. Am I still above 100? The answer, of course, is yes, right? So that means that I'm I may need to add an adjunct to help get them lower than that 100. Okay. So you start them on the ezetimibe, and then you bring them back a couple months later, you check their cholesterol again, and now it still is above 100. This is where you're going to want to add the PCSK9 inhibitor. Okay. Sometimes there's confusion on, well, do I stop the statin and the ezetimibe but put them on the PCSK9 inhibitor? And the answer is no. As long as they're tolerating the statin and they're tolerating the ezetimibe, go ahead and just add the PCSK9 inhibitor to that regimen. Don't replace it, just add to it. Okay. So that's your extremes of the primary prevention. Now, the next step is if you're in that 70 to 189 range, so that borderline range, the next question you have to ask yourself is, according to the algorithm, do they have diabetes? So this is where diabetes comes into play. If you have a diabetic who has a 190, greater than 190 LDL, it doesn't matter what their diabetes levels are because you're going to be treating them like the LDL greater than 190, okay? So it only matters if they are diabetic by them having that middle range of 70 to 189 LDL. If they have it, put them on a moderate intensity statin with a goal of lowering 30 to 49%. So we said moderate intensity statins, we expect a 30 to 49% reduction in their cholesterol or in their LDL levels. So that's why that's our range, that's what our goal is. Okay. So with that moderate intensity that I put them on, I expect that 30 to 49% reduction. But if they have multiple ASCVD risk factors, so in addition to being diabetic, they also are hypertensive, or they have known coronary arterial disease, those additional risk factors, then in the age 50 to 75, then the recommendation is actually to do a high intensity statin for these folks, because you want to be more aggressive in lowering their cholesterol levels, because if they have all these additional risk factors, you want to be more aggressive, because even with their diabetes being under control, with those additional risk factors, they're at a higher risk overall of having the event. Okay. Well, let's go back and let's say that this patient has a borderline, so 70 to 189 LDL, but does not have diabetes. Okay. This is where you're going to have to calculate their ASCVD using that calculator that I showed you. And then based on that calculation, you will then come back to the algorithm and start assessing what's the treatment recommendation for this patient. So we'll start off with, let's say that their ASCVD risk was less than 5% when you did the calculation. So what are you going to do? Lifestyle and risk discussion. You're not starting them on medications, you're just talking to them about the potential risk factors that they have that could, in the future, put them at risk of having an ASCVD. So, things again like the smoking, like the weight, like the lack of physical activity, those types of things, talk to them about that and try to get them to make the right lifestyle choices to continue to be low risk. Let's say that they are 5 to less than 7.5% risk. This puts them in a borderline risk. And now you're going to talk to them about risk-benefit kind of things for putting them on a statin to manage this. Other things are going to be like, let's look at risk enhancers. So let's look at their history. What things in their history might make them actually higher risk than being in this borderline that I'm just not capturing in that ASCVD risk calculation. If the patient's like, yeah, everybody in my family dies at the age of 40 because of a heart attack, those kinds of things, maybe they want to be more aggressive, maybe they want to be on a statin therapy. And if you do decide to start them on a statin and they're in this range, then moderate intensity statin. So what things are there that could put them at a higher risk that are not necessarily captured in the ASCVD risk calculator? Well, things like family history of premature cardiovascular disease. Let's say that this is the second time that they've had their cholesterol taken and their LDL remains above 160. They have chronic kidney disease. They have metabolic syndrome. They have persistently elevated triglycerides. So there's a number of things that would put somebody at a higher risk that is not necessarily captured in that risk calculator that we use to calculate that borderline risk. Metabolic syndrome, this is a term that tends to get thrown out. There's actually a criteria for this. So you need 3 of the 5 criterion. So abdominal obesity is one. So when you do a waist circumference in males where it's greater than 40 or women where it's greater than 35, that puts you at a higher risk of having cardiovascular disease. And for my Navy folks here, when we do the single site circumference, this is what that's coming off of because we're trying to have a healthier force, right? Another criteria to be diagnosed for metabolic syndrome is if you have triglycerides greater than 175. HDL, if it's less than 40 in men and less than 50 in women, that is a criteria for metabolic syndrome. If you have a stage 1 hypertension or greater, and if you have a elevated fasting glucose, so you're having like that pre-diabetes or impaired fasting glucose, whatever term you want to use this week, if that's there, then that is a criteria for metabolic syndrome. And you only need 3 of those 5 to meet the definition of having metabolic syndrome. Okay, let's go back to our algorithm. So now we say we calculated our risk for our patient. Now it's 7.5 to less than 20%. Now they are intermediate risk. Let's look at those risk enhancers and try to modify, address those if possible. Maybe we need to actually get a cardiac CT done to look at the coronary arteries to see if there is plaque formation already present. And I'm going to take that information and the recommendation, if there is evidence of risk factors or there is evidence of coronary artery calcium, then let's put them on a moderate intensity statin, and let's aim, because we're putting them on a moderate intensity, let's aim for lowering their LDL by 30 to 49%. And then the last part of the primary but borderline LDL levels in a non-diabetic is if their ASCVD is greater than 20, they are considered high risk. They should be put on a high intensity statin, and we would expect at least a 50% reduction in their LDLs because they are going, or we are putting them on that high intensity statin. Okay. So we have talked about all of this side of the algorithm. Questions about primary prevention? So now let's focus on the side that we haven't talked about, and that's your secondary prevention. So these are, again, your patients who have had an ASCVD event already. So they've had their heart attack, they've had their stroke, they have their symptomatic peripheral arterial disease. That is MINMAC. So that's what would qualify for secondary prevention. But the first question you have to ask yourself when we look at our algorithm is there a history of multiple major ASCVD events or one major ASCVD event plus a multiple high risk? And the answer is yes or no. So what exactly is that? So major would be they have had those ASCVD events, so they've had that heart attack, they've had that stroke, or they have symptomatic peripheral arterial disease. So do they have 2 or more of those, or do they have 1 of those, and they have a multiple high-risk conditions? Multiple means greater than or equal to. Okay. So are they 65 years of age or older? Do they have diabetes? Do they have hypertension? Do they currently smoke? Do they have a persistently elevated LDL despite being on maximally tolerated statin and ezetimibe? So looking for those additional risk factors that put somebody at a higher risk of having, in this case, a recurrent cardiovascular event. So do they have at least 2 of those and 1 major there? If they do, then they are considered very high risk, and you go down the very high risk limb of the secondary prevention treatment algorithm. And the treatment for this is, which should make sense, like if they've already had an event and they are high risk of having another event, let's be extra aggressive in treating their LDLs. So we're going to put them on that maximally tolerated statin again. So again, try them on that atorvastatin 80, try to start them on that rosuvastatin 40. Give them a couple of months, then come back and let's recheck their LDL. But this time, instead of it being less than 100 is our goal is actually to have it less than 70. Okay, so we're being even more aggressive in lowering that LDL level. If it remains above 70 and they're on that maximally tolerated statin, then go ahead and add ezetimibe. If they're on ezetimibe and that maximally tolerated statin, or they can't tolerate a statin at all because of the side effects, then put them on that PCSK9 inhibitor to try to lower that value down. Okay. So shoot for an LDL less than 70 in your very high risk secondary prevention. Let's say that they don't meet the criteria for very high risk. So that would be that they have one of these and at most one of these conditions. They now qualify for stable ASCVD. And when you go down the treatment limb of secondary prevention for stable ASCVD, it's high or moderate intensity statin. So they give you a little leeway, and that's where you can kind of talk to your patients, look at your patients, and see what would be the appropriate dosing to put them on. So like for instance, one thing that might put you, or want you to put you on as a high intensity version of this would be, let's say you have your patient who has had a heart attack, they are 64, their birthday is next month, getting ready to turn 65, and they have a history of diabetes. So yes, technically they meet the criteria for stable because they're not 65 yet, but a month from now they're going to be 65. So now they have another criteria that puts them at a very high risk, right? So let's go ahead and let's be extra aggressive with them. Let's go ahead and treat them. But the goal for the LDL reduction in this category kind of depends on which intensity of the statin you chose. If you chose high intensity, then I am expecting to get at least 50% reduction in their LDL. If you put them on the moderate intensity, I'm expecting that 49% reduction in their LDL. So don't think that you're going to get that 50% reduction if you just put them on that moderate intensity. That's not your goal. Your goal is to expect that reduction based on the intensity that you put them on, okay? Questions about the algorithm and treatment? So what's in the future? This is an FYI slide, okay? So one of the things we're seeing is that ASCVD risk calculator that I talked about is being replaced by the prevent risk calculator. The algorithm that we have is from 2018, so it's due to get updated. We already are seeing this being updated in the hypertension literature, where the prevent risk calculator is now being used as opposed to the ASCVD risk calculator. And the advantages of using the prevent is, one, you can calculate risk for people 30 years of age and older, not the 40. And it also gives me a 10 and a 30-year risk. So what is their 10-year? Okay, not that bad. But you're 30 right now. By the time you're 60, I predict your chances of having a heart attack, stroke, or peripheral arterial disease is this. So it gives you that breakdown. But you can also use it to calculate not only what the risk of stroke and heart attack is, but it also gives you the calculation of what's their chances of developing heart failure. So something, a pathologic condition that we didn't test for previously, I can now get some objective kind of data as far as what their risk of developing heart failure is based on their health. Other things that might be down the road is treatment guidelines for high lipoprotein A. We are seeing that high lipoprotein A is a genetic predisposition for cardiovascular events. So even though you may not meet the criteria for heart disease or meet criteria for being at risk for heart disease, because you have the genetic predisposition with this lipoprotein A, these folks tend to have premature cardiovascular disease. So these folks need to be a little more aggressive and start treatment sooner. And unfortunately, we don't have a medication yet that attacks the lipoprotein A directly. So we're stuck with statin therapies. There are trials, and there's some that are in like phase 3, that in the next 5 years may come out and actually be able to be prescribed to your patients with the genetic predisposition for this. But unfortunately, right now, there's nothing that we have specifically to attack the high lipoprotein A. And then other things that are coming down the line is you usually think of HDL, the higher the better. But is there a threshold where having too much good cholesterol actually could lead to disease? And that's something that we need to explore. Because we are seeing folks who have like HDLs of like 120, 130 actually having strokes. So is there too high? Right now it's, hey, the higher the better, it protects the heart, we're fine. But maybe there is a level that's too high. Unfortunately, the treatment might be a little difficult because what are the things that elevate your HDL? Good diet, exercise. So what am I going to do? Prescribe you McDonald's and sitting on the couch watching TV for 20 hours a day? You may love that, but I don't want to swing from, high HDL down to, now you have high LDL, and now you've got the worst of both worlds. So we'll see what happens in the future in that discussion. There's a lot of studies that are happening. This might be another topic, if you don't like your topic for your CI, you could look into, because there is a lot of research coming out now about that. So let's finish up talking about hypertriglyceridemia, okay? So we said triglyceride levels should normally be less than 150. Oh, but doc, my triglyceride is 151. It's highlighted red in the medical record. It has a big H next to it. What do I do? This is one of those topics that's kind of difficult because your patients are not going to believe you necessarily, because they're going to see these elevations and it's going to be marked as elevated, but you're going to be like, we're not giving you any medicines, let's just try to eat healthier, let's exercise, those types of things. So there's not a magic pill necessarily that can help with this. So we don't really get concerned, or we really don't label it as elevated until that cholesterol level gets above 175. And if it's in the range of 175 to 499, so this qualifies as a moderate hypertriglyceridemia, we're going to treat it with lifestyle changes. We're not going to treat it with pills. Not yet. It's not until that triglyceride level meets the severe criteria, where now it's greater than 500, that we actually are going to treat this condition with medications. And part of it is because it increases your risk of things, to include pancreatitis. So I know you haven't gotten to pancreatitis yet in GI, but one of the causes of pancreatitis is a severe elevation of triglycerides. So what do we have at our disposal? So moderate elevations, lifestyle changes. Severe, we have our fibrates, we have our nicotinic acids, and we have our omega-3s that can help us lower those triglyceride levels. The fibrates are going to be kind of our go-to because, one, they have the best response according to literature in lowering that triglycerides in those severe triglyceridemia ranges, where you can expect at least a 35 to 50%. However, if you give them gemfibrozol, you can expect up to about 70%. So you get a much more profound impact with gemfibrozol. The problem with gemfibrozol, though, is you combine it with a statin, you increase the risk of round kill. So you never are giving your patients a statin and gemfibrozol because you could kill their kidneys. But you can see, though, the fenofibrate does a great job in lowering it. You can have them on a statin, and you can still get a good reduction in their triglyceride levels. How does it work? So it's a PPAR alpha agonist, which is great. I'm not going to ask you about mechanism of action for it, but it is considered the best for lowering triglycerides. That's kind of the key point on this slide. Niacin or niacin, this is also an option for you. We typically think of this more as like, if I need to increase my HDL levels, I'll give them this. But it does have an impact on your triglyceride levels as well. So this could be something to prescribe, but the side effects for this oftentimes limit our patient compliance with this and the desire for our patients to continue to take this, particularly like the flushing that goes along with it, where they feel like they're on fire after they take such a large dose of this. So this has some limited utility just because patients may not be able to tolerate it. And then omega-3 fatty acids, we don't really know how they work, but they have been good, shown to be good at lowering your triglyceride levels. And then they also can help with raising your HDL levels. But that is also an option for your patients. The only thing that they don't typically like is they get a fishy kind of burp with it. But there are the lifestyle changes to help with lowering triglycerides. So just physical activity will drop it. Eating healthy can drop it. Something as simple as limiting your alcohol. So if they're drinking more than 2 alcoholic beverages a day, just by dropping that, you can see an up to 50% reduction in your triglycerides just by modifying how much alcohol that you're drinking. So you can see kind of what things can help with lowering your triglycerides. And this would be the recommended diet for your patients with elevated triglycerides and with elevated LDLs. None of this is surprising. We're told this is part of the food pyramid and all that kind of stuff, right? But in case your patients need some kind of goal, because a lot of your calorie tracking apps actually will have this built in to kind of help. But if they need a goal or they need that objective goal, here's a great list to help them be healthier. And then let's just finish by talking about metabolic syndrome. So we kind of talked about the criteria for this, but this could be one of the greatest risk factors outside of smoking that can have such a significant impact on their overall health. Because the things that go into making somebody have metabolic syndrome are the obesity, the blood pressure issues, and poor sugar control, whether it be a insensitivity to insulin with like your prediabetes or impaired fasting glucose, or they are diabetic themselves. So they have that true diabetes, elevations in their sugars, that will put them at risk, or that's one of the criteria for metabolic syndrome. So Let's try to address our patients who are at risk for metabolic syndrome. Let's try to correct those things because that will reduce their overall risk of cardiovascular disease with atherosclerosis. But the reason we emphasize this is this condition is a primary care problem. This is our battlefield in our clinical practice because we could intervene early on and prevent a heart attack in the next 5 years, prevent a heart attack in 10 years. You could prevent this person from being bedbound because of a stroke or a heart attack that limits them from being able to interact with their grandkids. So this is a primary care problem. Once they have the condition and they have a complication related to the condition, it's no longer a primary care problem. This is now the specialists that have to get involved. So do what you need to prevent your patients from requiring a specialist, because that specialist, when they get on board, something bad has really happened. So manage your patients, manage their risk factors, try to get their buy-in to take care of their problems. So, questions? That is all I've got for you.